Good afternoon, everyone. It's absolute pleasure to be here. I'm Shakira Grant, and today I will be wearing my intersection of an oncologist, but really as a healthcare professional. I will say full disclosure, I do not have a tech background, and this is my first conference here for open source, and so I'm excited to learn as much as possible from everyone here. Today we're going to take a small glimpse at what it means when we think about leveraging artificial intelligence to help close some of the gaps in access to care and health outcomes as it relates to different populations. We're going to anchor in two real-life scenarios, and we're going to see how bias can seep into these models and potentially be scaled on a larger population level. So what is my background that really gives me the authority to even talk about this issue? Well, as a healthcare disparities and access researcher, I've studied and worked with communities to learn what are the major challenges they face when trying to access care, and what are the main concerns they have as we are living in a more increasingly artificial intelligence-driven world. In addition, in my role in Congress, I had the opportunity to work on policies as it relates to artificial intelligence and trying to think about issues such as equity, fairness, reimbursement, and how do we protect privacy. So for today, in keeping with this conference theme for today, we're going to focus on bias. So let's talk about two case studies for today. We're going to see how bias shows up in health AI, and we're going to talk about some of the guardrails that can be used to help mitigate some of this bias. So I asked you this question to really stop and pause. I mentioned that I am an oncologist, which is a cancer doctor, and I need you to think about the gravity of this. What if AI misses a cancer diagnosis? For some cases, if AI doesn't quite get the text or the output right, it may be no big deal. But when we're dealing with healthcare, healthcare is oftentimes a decision where it could be a life or death scenario. And that is exactly the scenario that we find ourselves in whenever you think about AI being used, especially for things like making a cancer diagnosis. So I titled this, when we think about AI, especially in cancer care, one of the ways that this term is thrown around is to think about making precision medicine. But I asked this question, precision for whom? In this example, there are tools currently on the market that have been developed to help diagnose skin cancers. And what these tools have been found to do is underperformed in persons who have darker skin tones. What this translates to in real life is that people who are darker skin tones, black or other ethnicities, when those tools are used to try to detect a skin cancer, chances are it will say there is no skin cancer detected. Remember, I anchored this initial opening with what if AI misses a cancer diagnosis. So you can see that this is the same model, but it performs differently depending on whether it's exposed to lighter skin tones or darker skin tones. So AI can be the bridge that bridges care gaps, but in this scenario, when AI tools are being used to help diagnose skin cancers and they're missing skin cancers in darker skin tones, that same AI that was used for good as the intent could also act as the chasm that continues to widen these disparities. So let's think about this. What went wrong? Why did these models underperform in real life when exposed to those of darker skin tones? Well, it starts with data. So training data that's skewed toward lighter skin tones. In simple terms for me as a non-technical person, this means when the model was being developed, it was exposed only to images with skin cancers or suspicious lesions in those with lighter skin tones. So when you translate that into the real world setting or to the clinic and you show the model diverse images, it does not pick up the cancer at the same rate. It could also be labeling issue, labeling in terms of the data. And so skin tone could also be often underreported, and also lack of diversity, as I mentioned before, within the data set, meaning the model was just not exposed to those skin tones. So why is this important? So it's important because we have to realize that when it comes to developing these models, it is, especially within the healthcare setting, we're not just making a decision that is going to predict an outcome, and if it doesn't predict the outcome correctly, there's no big consequence. So we need to think about data and evaluation design, not just model choice, because in this particular example, this is what drove the disparity. So the real world consequences here is that this could lead to skin cancer diagnoses being missed, and to set the stage for those who may be less familiar with skin cancer, such as melanoma, this is already a cancer which occurs less often in Black persons, for instance, but when it does occur, it presents at a more advanced stage and is often more difficult to treat. So imagine if your tool is meant to detect the skin cancer earlier but misses it, it adds on top of what is already known as those systemic biases or inequities that exist between Black persons and those who are lighter skin tones. So flawed proxy equals biased outcomes. This is my second example that we'll anchor in today. So in this is another tool that was used to predict whether or not patients would require additional resources at home, additional support. And this particular tool has been used on millions of Americans. And what it showed is that when they looked to allocate resources, they found that persons who identified as Black actually did not require as much resources, despite being quite much sicker. So let me say that again. So despite being sicker than everybody else, this tool predicted that Black persons did not need the additional resources. So you may ask yourself, how did this happen? Well, when they took a look at the training data, they found that the model was using healthcare costs. So how much did Black persons use in terms of healthcare spending? And so that is flawed because there are inequities that are already baked into the system that limit how much access to healthcare Black persons have. So if you use healthcare utilization and costs, in this case, cost was the proxy, you're not really accounting for all of the other barriers that patients face in accessing care. So in that way, it doesn't really give you a true estimate of their need because it looks like they're not using the healthcare system as much, and therefore they're not spending as much in the healthcare system. And so the way to get around this particular case underscores the fact that there is a danger in relying on what you view as neutral proxies. In this case, thinking about healthcare spending. So we need, whenever you're designing and training your model, you need to think about the data, but you also need to think about what are you actually measuring and the implications for what you are measuring on the population health. So you need intentional design choices in healthcare algorithms in order to avoid perpetuating systemic biases. So in this example, which is a well-known example that I've given here, the correct way to correct for this would not have been to look at actual healthcare expenses, but to look at burden of disease, for example, and use that to allocate resources. So how does bias enter the pipeline? So 3 main ways it does. So data, evaluation, and then after the model is deployed or the tool, in the operations. So what is the post-deployment follow-up? So data we've already captured, and we talked about underrepresentation, how data has bias in it. We showed it in the example, especially with resource allocation. And then evaluation. So we don't necessarily have the subgroup metrics that help to tell us how models are performing across different groups. So again, if you do not have diversity in your data set, it means you're not able to have sufficient subgroup analyses conducted that can then be translated into what this model is likely to do in the real world when exposed to diverse populations. And then the third one is operations, is more in the post-deployment stage. So it's great. Suppose you did do all the great things with getting your training data to be aligned and to be diverse, and you did your subgroup analyses, but you need to monitor post-deployment for data drift and for other issues. So why does this matter? So I started this with a what-if moment. What if AI misses a cancer diagnosis? You can replace cancer with any other diagnosis, especially in healthcare. So this matters because in these examples, it shows that patients who actually had additional needs because they were sicker, they did not get the resources that they needed. It led to delayed or missed diagnoses, in this case, skin cancers. So this is direct implications for those within the dermatology space. And while it may seem like there may be some small percentage performance gaps in models, the reality is that when you leverage this in a population sense, this can actually lead to real large-scale population harm. And the key that I want to drive home here is that when you're thinking about AI and why we need to think about governance is because ethics, safety, accountability, privacy, transparency, those cannot be afterthoughts. They need to be from the design of your AI model or machine learning model. You need to be thinking about those, especially within the healthcare space. So let's think about how we can fix. So 4 things. So what are we really optimizing? So that's the first thing. So ask yourself, what are you really trying to optimize? In this example, I gave you the example of using healthcare costs or spending. And so you need to think about replacing that with more other relevant outcomes that can help address some of these systemic inequities that actually can perpetuate bias. You need to think about the causal sense. So will improving the target actually improve patient health? And in this case, you can see that if this model, and they actually reported this in the paper, if they had used disease severity, it would have led to almost a 20% increase in the number of people who actually received, Black persons who actually received the resources that they needed. So it does make a difference. And the guardrail is to document the target choice and know the limitations. So target choice meaning, in this case, if you choose disease burden, know what the limitations are likely to be in terms of how your model is going to perform. Number 2, get the data right. So this is a big one. How do we create diverse data sets, especially when large language models, or I should say in this case, foundational or frontier models, are built from data sets that we know contain many of these biases? How do we correct for those moving forward? Because investing in creating data sets that have diverse data, diverse participants, is expensive, it's timely. And so we need to be thinking about the data sets, recognizing the limitations, standardizing labels, capturing settings, making sure to identify rare or edge cases, and thinking about that. In this case, for instance, diagnosing skin cancers in people with different skin tones, that could be where you need to have a physician in the loop to help identify those potential cases that may not be readily picked up by your model. So this is a simple one, but if there's no demographics, there really should be no deployment. If you as a developer or a vendor is trying to sell your product to the healthcare setting, and there's no demographic data, you can't tell how this model is going to perform across diverse groups, then this really shouldn't be something, especially in healthcare, that should be deployed. Evaluate like you mean it. So always report subgroup metrics. Even if your subgroup analyses are small, it helps, especially within healthcare, to know whether there are some in-group or across-group differences. Stress test thresholds, because you want to avoid a one-size-fits-all approach. And then think about performance shift, especially in this scenario where we talked about the dermatology case or the skin cancer case. See whether or not performance shift when you alter things like skin tone or ethnicity. And then this is like in quotation, but maybe you need to think about a fairness confidence interval in the evaluation of your pipeline. And then monitor. Is not enough to just say, okay, we're going to do all these things in the development stage. We've done our part. We'll pass it on now to the post-deployment and we don't need to do anything else. You need to monitor because it may be that there are differences that are detected over time, and then you get that feedback, you get that data, and you're able to then continue to improve your model. And then again, this human in the loop or human on the loop, however you want to posit it, but this is where you want to think about having cases that may be on the fence, where you're questioning whether the model is truly performing as it should, having that human in or on the loop being a critical part of what you do. So finally, I want to leave you with this in terms of thinking about data, thinking about AI, and thinking about whether or not AI will truly be that bridge we need to start fixing some of these gaps in healthcare that currently exist, or if it will truly cause that chasm. So the first is we need to find the right objective, the right data, talked about the data set, right evaluation, and we need ongoing monitoring. We need governance. We need to demand transparency from vendors, require external validation, and we need to also address all of the other factors that I didn't even touch on, such as accountability, when AI gets something wrong, who's to blame, other things like fairness in terms of access to these particular tools. Remember that the same tech can give you different choices, and this can be the difference between widening gaps or closing them. In order to really move forward with AI in healthcare, we need to think about equity by design. We cannot let it be an afterthought, and this is going to be a requirement for your stack. With that, I want to say thank you, and please feel free, you can connect with me on LinkedIn, and